تقريبا دلوقتي في مصر، ويسعدنا انه هو نشارك في جلسة البورتال هايبرتنشن. والحقيقة برضو مزيد من السعادة ان انا اقدم يعني صديقي واخي الرائع اميتاب باتشان مصر، استاذ الدكتور محمد شاكر. هو غني عن التعريف الحقيقة الدكتور محمد، يعني فأي كلام في حقه مش هيوفيه. والحقيقة هو مبدع جدا في العملية اللي هتسمعوها النهاردة عن التبس. الحقيقة هو هيتكلم على المحاضرة titled Percutaneous Ultrasound Guided Reversed Gun Side Tips / Dips. اتفضل يا دكتور محمد.
Assalamu alaikum. Thank you, my dear friend and brother, Professor Dr. Mohammed Lourai, dear chairman, colleagues, professors, and it's a pleasure for me to participate during the 3 days of the meeting this year. It's a pleasure and honor, and I always like to be with you in this elegant meeting, talking about the percutaneous ultrasound guided reverse gun sight DIPS technique. As you know, TIPS, transjugular intrahepatic portosystemic shunt, sometimes it becomes a challenging procedure. Actually, it is a challenging procedure, but sometimes it is more challenging procedure in some situations, like in portal vein thrombosis, chronic portal vein thrombosis, hepatic vein occlusion, the Budd-Chiari, and sometimes there is unfavorable anatomy, like in case of post-transplantation. So we may need some modification of the technique of TIPS in such situations. One of such techniques was the gun sight technique, which was invented by Professor Haskell in 1996, actually. And this was the case for which Haskell invented this technique. This was a case of Budd-Chiari syndrome with inserted TIPS, and the patient recurred with occluded TIPS many times, and he recanalized the TIPS stent, and finally he did a recanalization, but the patient still has refractory ascites. So still there is high portal hypertension. So there was a difficulty to go through the standard TIPS technique to insert another TIPS. So he invented this gun sight technique to insert another TIPS beside this already inserted TIPS. So what is the gun sight technique? This is the technique of Haskell. The standard gun sight technique is not our technique. We'll talk later about our technique. It depends on insertion of 2 snares, one in the hepatic vein, one of the hepatic veins, and the other in the right portal vein or left portal vein, and then he tries to connect both snares by puncturing through the percutaneous puncture, and he snares the wire and then continue the procedure. The idea is to create the track between the right hepatic vein and the right portal vein, or between the systemic circulation and portal circulation, the idea of TIPS. So how he can do this? He catheterizes the hepatic vein, one of the hepatic veins, as you see here, and also do another puncture, which may be transsplenic puncture or transhepatic through the left portal branch to reach the right portal branch, okay? And then he put a snare in each of them, in the hepatic vein and in the right portal, and he tried to connect both of them through percutaneous puncture by a needle, so the needle passes through both snares. So this is the created track between both snares, between the right portal and the right hepatic vein. And then he snares this guide wire from above, from the transjugular route, and also from the left approach or the transsplenic approach to direct the wire into the main portal vein. So this is the way how he will insert the TIPS. And then continue the procedure as any standard TIPS technique, transjugular along over the wire, and the lower end at the portal and upper end at the IVC, or the junction between the hepatic vein and the IVC. This is the classic or standard gun sight technique invented by Haskell. What are the advantages of this technique? It's suitable in cases of portal vein thrombosis with cavernous transformation. It's difficult in such cases to perform the standard or classic transjugular TIPS technique, so can use this technique. Technically easier in case of unfavorable anatomy, and creation of tips without dedicated tips kit. As you saw, we didn't use the puncture needle of tips. So these are the advantages. So it is less costly than standard tips. What are the disadvantages of this technique? Extra access. We have extra access to get a snare inside the right portal branch, whether through the transhepatic approach, through the left portal, or transsplenic approach. So we have extra puncture. So we may have longer procedure time with higher radiation exposure. So in our institute, we use another technique in such difficult situation, which is the ultrasound-guided reversed, or let's say modified Gansite technique. In such technique, we use only one snare with only one puncture. So through the ultrasound guidance, usually through the intercostal space, we insert a snare in the IVC, and we do puncture under ultrasound guidance of the right portal branch in intrahepatic location, and put the wire by the snare in the IVC. So just one snare in the IVC in case of Budd-Chiari, or in the hepatic vein in case when the hepatic veins are patent. We can apply this technique in 3 clinical scenarios. The first scenario, in case of post-cirrhotic portal hypertension with patent hepatic veins, yes, we can do it. We can puncture from the portal vein to the right hepatic vein, for example. We can do it. But usually we use the classic tips technique in such situations. In Budd-Chiari, this is very helpful technique in case of Budd-Chiari with occlusion of all hepatic veins. As we know, indicated cases in Budd-Chiari for tips are cases with occluded all hepatic veins with patent portal vein and IVC. This may be one of the main indications for this technique. And in case of post-transplantation indicated for tips, sometimes the anatomy is not favorable after liver transplantation due to hypertrophy of the graft or rotation of the graft. So this may be a helpful technique also in such scenario, as we will see in this case. This is a case 12 years post-transplantation with recurrence of chronic parenchymatous liver disease and portal hypertension and refractory ascites, and we insert a retrohepatic IVC snare, and then we do the main step of the procedure under ultrasound real time. This is the puncture needle, this is the right portal, this is the right hepatic, this is living donor case, so there is right liver graft, and then we do portography to be sure that we are inside the right portal branch, and then we continue puncturing through the liver parenchyma to create the track between the right portal and the right hepatic vein, as we see here, near its junction with the IVC. So we do reversed puncture from the portal to the right hepatic, not from the right hepatic to the portal. And we confirm again the puncture in the right hepatic vein, and we insert a guide wire and snare it through the transjugular route. So it is only one puncture with only one snare, compared to the classic Gansite technique. So this is a through and through wire. One end from the transabdominal route and one end from the transjugular route. And then we advance our dilatation balloon, 8 millimeter balloon, over the wire to dilate the tract between the portal here and the IVC. Here is the site of puncture of the hepatic vein. And then we advance our 10 French sheaths down to the right portal. And then we advance through we keep the through and through wire in place for safety till we be sure we are inside the main portal by advancement of a manipulation catheter with a Terumo wire beside the through and through wire from the upper end of the 10 French sheath, and guide them toward the main portal vein so that we can insert the stent after that. And we remove the through and through wire and insert our stent, and this is the final outcome after insertion of our TIPS stent. This is dilatation, and then we insert the TIPS stent after that. We advance the cheese to the main portal, and this is the end result after insertion of the stent. So the advantages of our technique that we use only one puncture, no extra puncture, compared to the classic Gansite technique. It is real-time ultrasound guidance during advancement of the needle into the portal vein. decrease radiation by use of ultrasound guidance, decrease procedural time, and also, again, lower cost compared to the classic TIPS technique because we don't use the complete TIPS set. We only use the long 10 French cheese and the puncture needle and the balloon and stents used only also in the classic TIPS. So we are lower in cost compared to the classic TIPS. We have some technical considerations in this technique. The main issue is where to puncture the portal vein. This is very important to avoid complication in terms of intraperitoneal bleeding. So try always to puncture the right portal vein in an intrahepatic location, of course, but not so peripheral and not so central, not so central to avoid the intraperitoneal bleeding, and not so peripheral to avoid kinking of the stent. You need to have smooth angle or smooth curve of the stent as if you are inserting the stent from above. So the first order branch is a good site for puncturing of the portal vein, and it also depends that you can be able to put the or adjust the retrohepatic IVC with the right portal vein in the same plan during your puncture by the ultrasound guidance. By ultrasound, you know the extrahepatic location of the right portal vein by this fat around the main right portal vein. Avoid puncture at this area completely. This is an extrahepatic location. Although it seems here that the liver capsule is here, and you may imagine that if you punctured here, you are safe, you are inside the liver. No, if you have this fat, avoid puncturing through this fat. This is an extrahepatic location, so go here, distal to this fat, okay? The other technical issue is to avoid puncturing. You are punctured from percutaneous, so the right hepatic artery is in your way to the portal vein. You go this way, so the right hepatic artery here, and to the right portal. So avoid to puncture, of course, the right hepatic artery, and to have your guidance, ultrasound and Doppler, you can avoid easily the right hepatic artery. So our take-home message, portal systemic chance creation can be challenging in patients with portal vein thrombosis, Budd-Chiari syndrome, and unfavorable anatomy. Although fluoroscopic guided gun site technique can facilitate TIPS insertion, however, it has its advantage of extra puncture, longer time, and the radiation exposure. Ultrasound guided reversed modified gun site TIPS technique avoid extra puncture with the advantage of single real-time ultrasound guided puncture, less radiation exposure, shorter procedure time, and less costly compared to the classic TIPS. Thank you very much.
Thank you very much for my friend for this elegant